Good evening. I am presenting on behalf of Medicine 5. So, here, 59 years old gentleman, in Feb 2024, he developed a left-sided scrotal pain with dysuria for 4 days, along with one episode of low-grade fever. Then, on examination, he was found to have phimosis, and there was a local rise of temperature noted over the left hemiscrotum with a minimal tenderness, but skin over the scrotum was normal, no fluctuation, and testes was normal. Rectal examination showed benign prostate enlargement grade 1. So he was seen under CMC urology department and diagnosed as a left epididymoarthritis, and he received a amikacin for 5 days and ampicillin for 5 days and planned for circumcision on OPD basis. The same patient in the during second to third week of March 2020, the second to third week of March, he developed again high-grade fever with chills and rigor with no other localizing symptoms. He also complained of mild skin peeling. But for this complaints, he was evaluated outside. And outside, the Vidal came positive, and he was treated as enteric fever. And during outside, he received 5 days of injection ceftriaxone, 5 days of cotrimoxazole, and amoxicillin. However, he continued to have, he was well in between, and then again he started to have persistent fever spikes. On day 12 of the fever spike, he started to develop alteration in the sensorium and also complained of headache, which is not associated with the vomiting or diplopia or seizures. Hence, they brought to our CMC ED for further management. When came to ED, the vitals were stable, blood pressure 130/90, respiratory rate is 20, saturation 98%, he was afebrile, and GCS is 11/15. Other system examinations were normal. CNS system examination, the no focal neurological deficit, bilateral plantar flexor response, no meningeal signs. So when he came to ward, he was we have noted that he has like this is a picture from Google, but our patient also had a same skin lesions over the lips. So what is your diagnosis? So, like you, we are also taught herpes simplex encephalitis. So, first differential is viral encephalitis, most likely herpes simplex virus encephalitis. Other differential we are considered as partially treated pyogenic meningoencephalitis, acute febrile illness with encephalopathy, then septic encephalopathy secondary to urinary tract infection or epididymoarthritis, and then in view of present climate heat-related illness also we considered.
So, just come back. I don't know what happened to this patient, but it's a clinical dictum that you would never have HSV encephalitis and a hepatic lesion together. Okay, that never happens, usually, for all practical purposes.
Yes, sir.
So that's something to remember. When you would see this with pneumococcal pneumonia, many of these things you would see your patients developing lesions, but that never happens with the HSV encephalitis. Okay, that's something to bear in your mind.
Yes, sir, sure. Sir. So, initial investigation showed elevated total counts of 27,800 with the toxic changes in neutrophils, and LFT showed rearrangement, bilirubin elevated more than 2 with elevations of AST, ALT, and alkaline phosphatase. CPKs with the normal limit, urine protein, blood culture, and or acute febrile workup came negative. So we have done CSF. CSF showed a total WBC count of 15 with a lymphocyte predominant, and CSF glucose mildly reduced for protein within normal limit. We have sent a CSF for a bacterial culture and sensitivity, expert TB, then MG, everything came negative. However,
do you think that the CSF protein is normal?
Mildly
elevated, isn't it? So yes, better to call it abnormal. Yeah. Yes.
Then we have sent for multiplex viral PCR. It came HSV1 positive.
It's a very curious finding. Huh? I think you should try and report this. Usually never seen together.
So we have diagnosed this patient as herpes simplex encephalitis. Initially, he was treated with the empirical ceftriaxone, doxycycline, vancomycin, acyclovir. After 5 days of a multiplex viral report, we have stopped all antibiotics, and he received a total duration of acyclovir for 14 days. But in the ward, after 7 days of acyclovir, there was a remarkable improvement in the sensorium. CRP also declined to 12.7 from 58.5, and the liver function test, liver enzymes also normalized. So, however, he was noted to have low-grade fever spikes, but although he was clinically well and he has no complaints, sensorium improved, he was discharged and advised to follow up in OPD. So when he came to OPD on 24th April, this photo is obtained with consent. So he's complaining of within like 4 to 5 days after discharge, he's complaining of skin peeling, fissuring, and tightening since 23rd April 2024. So and he was noted to on examination, he was noted to have exfoliative skin lesions involving the face and involving the front and back of the trunk, and there is a tightening also. He is not able to open the mouth also. He got so. Then we have looked up the review, the OPD blood investigations. It showed this is the 24th OPD when it came to OPD. Total count is 18,300, and the marked finding is there is a eosinophil of 18%. When we then only we have looked back and we noticed that there is a marked elevation in the ward during the ward stay itself. There was a marked transient elevation in the eosinophils. From 6th onwards, it started to elevate from 6%, 12%, 13%, 18%, and now to OPD it has reached 18%. But because the patient was clinically well, we didn't work up on the elevated eosinophil counts. And then when he presented to OPD, the LFT is markedly deranged. Like bilirubin is more than 3 milligram, and then AST, ALT enzymes are more than 5 times elevated. And CRP also from 12, it has gone up to 147 within 5 days. So at present, what is your diagnosis? So now the syndrome complexes, the patient now presented with a fever, actually as fever, a rash, skin rash, and the eosinophil
I
symptoms.
think they all know it. They're just not opening.
Eosinophilia.
You can point one of your colleagues and ask them to confess.
And the liver dysfunction. Organ involvement. It will come in the acronym itself. If you expand that acronym, we can get diagnosis.
Since we have come thus far, why can't you tell it also? If the interns know, what is this? Have you heard of a dress syndrome? That is what she's trying to get at.
So we thought the dress syndrome. So dress syndrome, it's like skin rashes, eosinophilia, and systemic symptoms with like any exposure, prior exposure to drug. So that is the components of the dress syndrome. So to confirm, we consider the probability of dress syndrome at this point. So we have done a Regiscar. Regiscar score is the score for the diagnosis of the dress syndrome. So we have did Regiscar. Our patient had fever, eosinophilia, skin rash, and the organ involvement of liver. So the score will come 4. Less than 2 is unlikely. 4 is more than 4 is probable dress syndrome. So, considering the dress syndrome, we have contacted dermatology for further help, and these are all the antibiotics he has received for the past 2 months. So, with the help of dermatology, we have concluded that the most likely culprit drugs here for this patient is beta-lactams or Septran. So, before
Septran, no?
Sir, cotrimoxazole, sir.
Why did he receive that?
That epidermoarthritis in first sorry, sir, due to the enteric fever in the outside.
That's some time back, no?
Yes, sir.
Late onset dress.
Yes, sir. Within like 2 weeks, 2 to 3 weeks, he received ceftriaxone,
okay.
beta-lactams. So, I'm just briefly highlighting about the clinical relevant points of dress syndrome. So, dress syndrome is a severe idiosyncratic drug reaction. It usually has a prolonged latency period, 2 to 8 weeks after the initiating the offending drugs. Unlike other drug reactions like Stevens-Johnson syndrome, toxic epidermal necrolysis, which is presented with a short latency period. However, a dress syndrome presented prolonged latency period of 2 to 8 weeks. It has a variety of clinical manifestations such as cutaneous manifestations, urticaria, vesicle, bulla, erythroderma, facial edema, visceral involvement, hepatitis, pneumonitis, myocarditis, pericarditis, nephritis, and colitis. Mortality is around 10%. The term DRESS was first introduced by Boquote. That's why I named them my presentation as Boquote disease. So I want to highlight this pathogenesis to convey one clinical.
Not highlighted. Are you going to say anything particular from there?
The pathogenesis, sir. Yes, sir.
What is it?
Sir, the pathogenesis of DRESS syndrome will lead to reactivation.
Unless you want to link something that would teach, yes, these pictures are essentially very confusing.
Yes, sir. Sir, you
want to say 2 lines?
Yes, sir. Sir, actually, what happens in the patients who are developing DRESS syndrome will have a deficiency of the drug metabolizing enzymes. So that will lead to accumulation of the drug metabolites. The excessive accumulation of that drug metabolites will lead to the activation of the drug-specific T cells. This kind of immune dysregulation will cause hypogammaglobulinemia, will cause a suppression of the adaptive immune systems. So the clinical relevance of this is there was a transient hypoglobulinemia will lead to the reactivation of the herpes virus group, human herpes virus group observed, especially with the Epstein-Barr virus and human herpes virus 6 were observed. So this is the study done in the patients with the drug-induced hypersensitivity syndrome. They have found all the patients with drug-induced hypersensitivity syndromes were observed, and they monitored the serial titers of the IgG and the IgM antibodies to the herpes virus group, such as HH6, HH7, and cytomegalovirus. In addition to the antibody titers, they also monitored the viral DNA levels also. In a final conclusion, they found that that there will be reactivation of the HH6, human herpes virus 7, and cytomegalovirus and Epstein-Barr virus was noted as per this pathogenesis because of the immune dysregulation. So in our patient, usually the high risk drugs were anti-epileptic drugs. But in our patients, the anti-sulfonamide groups of drugs, vancomycins and beta-lactams were the culprit drugs we found. So this is the treatment algorithm. So the treatment DRESS syndrome, the initial treatment management is we stop the culprit drug, and then symptomatic treatment with antipyretics, antihistamines, and emollients is the initial management. When the patient has non-severe DRESS syndrome. Non-severe DRESS syndrome means there is no other organ involvement, only skin involvement with mild liver dysfunction. Mild liver dysfunction in the form of the bilirubin elevation or the liver enzyme elevation less than 2 times the upper limit, labeled as non-severe DRESS syndrome. It should be only the monitoring of the parameters only advised. But the patient is a severe DRESS syndrome. Severe DRESS syndrome means the liver enzyme elevations is more than 5 times the upper limit. The bilirubin is more than 2. Creatinine level is more than 2 times the abnormal baseline. Urine output is less than 0.5 ml per kg per hour. Or there is any pulmonary involvement or cardiac involvement. Patient will be advised to take a steroids 1 mg per kg. And the main key in the management of the DRESS syndrome is gradual tapering over 4 to 6 weeks, over weeks to months. Because there are many studies have shown that fast tapering of the steroids will again precipitate a severe DRESS syndrome. So gradual tapering is the key in the management of the DRESS syndrome. If the patient is not responding to steroids or developing steroid related complication, then cyclosporine or immunofluorescence or IV immunoglobulins also indicated. But we already we have noticed that there will be activation, viral reactivation in DRESS syndrome. In those times, we can treat with ganciclovir. So in our patient has a Regisca score of 4, and we found the culprit drug of beta-lactams or Septron, and we have done skin biopsy. Skin biopsy histology also proved the skin lesions of drug-induced etiology. So in our patient, because of the enzyme elevations and bilirubin more than 5 times and the bilirubin level is more than 3, we have started him on steroids 1 mg per kg per day and planned for slow tapering. While on the tapering, while at the time of discharge, our patient LFT normalized. And at time of discharge, the eosinophil count also from 18, it came back to 0%. But he continued to have persistent.
This is the third problem. I think it's time to wind up. He has some stuff for his back.
Yes, sir.
Did he do okay?
Yes,
Did
sir.
he do okay? Sure. I think this is your summary point.
Yes, sir.
Sure.
So now we are retrospectively thinking that the HSV encephalitis he presented is probably a viral reactivation.
Hold on to that thought. I'll come to that. Okay. Anybody wants to ask her any questions?
Can you know about the temporal profile of organic suicide? So you say that initially if everything improved, was that you're saying that's because the HSV was causing the ACLD to rise? Because you said that he came in with elevated bilirubin, then by the time he discharged, everything had improved. So if that was rest caused by the drug, everything had already improved by then. And you're saying after the rest happened, it got, the herpes got reactivated and everything. So everything subsided. Why can't acyclovir be the drug that caused?
Actually, we have searched for acyclovir. There is no one study reported acyclovir causing Dress syndrome. It is very, very rare. Even no one reported. Yeah.
My question is the reverse. I'm saying, why did it improve then? It improved and then worsened. So if it was breast that caused the whole thing, how did it improve?
Actually,
and then why did it worsen the second?
While looking up into the pathogenesis of the Dress syndrome, what we found is when the Dress is initiated, there will be an increase in the eosinophil count. But the immune dysregulation, everything takes 2 to 8 weeks. But after the 8 weeks, only the symptoms, the liver dysfunction will start to manifest. In between this period is this period is the correct period for the virus to reactivate. So we are thinking that the patient with HSV encephalitis presented between 2 to 8 weeks. That is our presentation. So from that liver dysfunction is due to the encephalitis that improved. But at the time of OPD visit, we thought that the actual Dress syndrome he presented with. That is the pathogenesis. We have studied. We have in multiple articles, and we thought.
So the hypogammaglobulinemia happens before
the Dress itself is come. It takes around 2 to 8 weeks to manifest. During that time only is that the active T cells will activate virus also. That is the pathogenesis proposed in multiple articles.
Again, the issue is about the temporal profile.
Yes, sir.
Just a comment first. One could be a facility speaks to the patient who can't came to your OPD after follow-up and then present everything else as a timeline as a past history because you're concentrating on the test. But anyway, if you had to apply the law of parsimony to this, was the epidermolysis in any way related to the rest of the illnesses?
No, sir, for completion purpose.
I'm just wondering, I was doing a few research today and I'm finding some cases of HSV1 used epidermolysis. Then if you look at Scott's protocol, during your admission, urology there were no ulcers or lesions.
No, sir. No, sir.
I'm not sure if this person was just so unlikely to have problems one after the other, or there is any logical difference. I do not know.
The theory is that the breast comes out of the hypogammaglobulinemia and the HSV reactive. But in that case,
it's completely different. So we have a MRI correlation when we came with the HSV on encephalitis or
yes, sir.
Here an MRI.
Yes. Normal, sir.
It was normal. This HSV1 or other viral reactivations associated with Dress syndrome, do they manifest equally with viral diseases?
Yes, sir. Actually, studies we didn't look up, sir. But
it's common for you to find either HSV or EBV encephalitis. Patients who have reactivation of the viruses because of the disease.
There was studies done to look for titers, serological evidence.
There's a lot of debate about whether this causes that or because the catalytic protein do they actually cause virus diseases?
That we no, so we didn't look up.
I also do not know. I have seen a lot of patients who have reactivation and high titers, but never seen a patient who actually develops an encephalitis because of ventilation.
Yeah. So anybody else wants to ask anything else? So I think you highlighted many important things, but one of the things that went a little bit amiss was that these are all latent viruses. They always reactivate when there is a significant systemic illness. But as Amit said, you would never usually see clinically manifested disease.
Okay.
Okay. And this whole thing of running behind viruses in dress came about when people realized some of the patients with dress go on to have recurrent episodes. So they thought that whether these viruses acted as triggers to bring about subsequent episodes. But you would never see, because they have identified CMV, if you will not see CMV gastroenteritis or CMV encephalitis. So the word you used was correct. It's a reactivation, but it's not a clinical disease. So that part you need to take. The other thing you may have to think about is that if you walk into MICU today and send CMV PCRs on 10 patients, at least 2 or 3 patients would be positive. And anybody who is ill seems to have a detectable looks like the sicker you are, the chance you have reactivation is higher. So it's very difficult to say that whether this drives that. Very likely, I feel it's a bystander thing. It doesn't have really anything to do with the influencing the disease per se, is what I feel. But it's good that you just wanted to ask you one more thing. How good is HSV1 diagnostics, you feel? Is it good sensitivity and specificity? It's very good, huh? It's very good, the PCR is. So if there is a consistent clinical syndrome and you have HSV1 picked up in the CSF, you're dealing with HSV1 encephalitis usually. Okay, so yeah, that's something. Thank you.